Good afternoon, everyone, and welcome to the Be Well Harm Reduction Echo. My name is Andrea Roche. I'll be facilitating our session today. I want you all to know, you probably saw this when you joined, we are recording these sessions for later distribution. So please know that nothing you list in the chat is available on that recording. I just have some housekeeping before we get started. To help us with attendance, can you share your name, affiliation, and email in the chat function? To access that chat feature, just navigate to the bottom of your Zoom window and click on the chat bubble and enter your info there. And thank you. This is just to help us keep a full record of attendance for these sessions. We are expecting a lot of participants today, so please do stay muted unless you are speaking, and try to remember to mute yourself after you've spoken. We have a lot of people here, so it's important to remember that you can mute yourself. And if we will try to mute you if we see you aren't able to get to the controls. To mute, if you joined by computer, select that mute microphone icon in the bottom left of your Zoom window, or if you've joined us on phone, to mute and unmute, press *6. Just note there's a little bit of a lag. And we also encourage you to use the chat to share comments, share questions. We'll be monitoring that throughout the session. And of course, as always on any ECHO session, note that no protected health information is allowed, either in the chat or spoken in our discussion. Towards the end of the session, the Be Well Texas team is going to send out in the chat a link to a post-session evaluation survey. Anyone who fills this out is going to be entered into a drawing for a $30 Walmart gift card. So we encourage everyone to participate, not just for the drawing, but also to give feedback that helps shape future sessions. And know that that survey will stay open for 1 week after today. Our didactic today is on considerations for harm reduction and healthcare when operating in a contaminated drug supply environment, presented by Claire Zagorski. And following that, we're going to hear a case presented by Sean Southern, a member of the learning community. So we're going to kick the session off with some introductions of the hub team, followed by didactics and some Be Well programming announcements, our case presentation, and then we'll open up the session for open discussion. So thanks again, everybody, for joining us. And this space is really what we make of it and what we bring to it. So I encourage everyone here to share your experiences, your curiosity, and your insight into our conversation today. So without further ado, let's do some introductions of our hub team. I'll start with you first, Aaron.
Hey guys, happy to be here. Thanks to everybody who's tuning in today. Hope we can be helpful. Aaron Ferguson, an outreach manager in medication-assisted treatment, methadone access, and then I'm on a leadership team of the Urban Survivors Union, a national group of directly impacted advocates for drug user health. Happy to be part of the discussion today.
Thank you so much, Aaron. Chris.
Hi, everybody. Chris Aber. I'm with Southwest Recovery Alliance. We offer harm reduction. Basically, we're just trying to create space where people who use drugs can come, receive the resources they need, and receive it with respect and dignity. I've also, at the national and local levels, worked around hepatitis C reform, as well as policy changes. And I just realized right before being introduced, I spent like 20 years receiving services and using drugs chaotically, and now I'm about 20 years on the giving those services, and so it's really good to be here.
Thank you so much, Chris, for joining us. Andrea.
My name is Andrea Handler, and I'm a project coordinator for the CSTAD and for the ECHO project. I'm happy to be here. Thank you.
Thanks, Andrea. And Claire, will go to you next.
Hey, y'all. I'm Claire Zagorski. I'm at the UT Austin College of Pharmacy in the PharM program, and I'm a harm reductionist, and I have been for about 10 years, and I'm also a paramedic. And I'm going to be talking today. And I come at this work from doing a lot of wound care and education and kind of community building around people who use drugs and harm reduction, trying to push for better policies and outcomes. So I'm very excited that y'all are all here today.
Thanks so much, Claire. And you've queued yourself up, actually. We'll go on and move into didactics. Claire, when you're ready, you should have screen shareability and go on and share.
How does that look, y'all?
Perfect.
Excellent. All right. Well, again, thank you everyone for being here. My name is Claire. I'm at the UT Austin College of Pharmacy, and I'm going to talk a little bit today about operating and doing what we do in a nice general sense in the contaminated or polluted drug supply environment in which we find ourselves today. This is my disclosure. My position at UT is funded by Texas Health and Human Services, so what I talk about today does not necessarily imply an endorsement by them or the US or Texas government. So just real quick, I'm not a very formal speaker at all, and I'm very big into collaboration and community and open dialogue. So if you have a question, just for the sake of time, please go ahead and drop it in the chat and we'll make sure to address everything. And then we can kind of discuss openly during the Q&A and discussion portion. So I'm going to kind of talk about the then and now of this situation. A lot of us already know this, but the narrative around the contaminated drug supply in the US and Canada tends to be focused really heavily on fentanyl. And fentanyl is the granddaddy. It's the one that we all know about. It's the one that's finally made it into major headlines. Like, it's really permeated our consciousness and our awareness. And fentanyl is certainly still the big driver of overdoses and other kinds of drug poisonings. But we are also getting into a context over the past few years where it's not just fentanyl. We're seeing a splintering or proliferation of the drug supply. So things used to be a lot simpler. So we used to have a fairly finite handful of substances that we had, and there's an asterisk on that because there's always been some psychonauts out there, right? There's always been a certain amount of bringing in kind of lesser known experimental substances. But for the most part, the major picture used to be fairly succinct. It would be heroin as opposed to what we have now, right? So this used to be good for a lot of reasons, and that there was a lot more predictability for people who use drugs. But then on the medical side, this was also good because the playbook was clear. We knew what we needed to do with a patient if there was something involving drugs. So if someone came in experiencing an overdose, we would know that it would be a pretty straightforward opioid overdose. Naloxone was a well-known entity at that point. We knew what to do. We were good. So we have a very different context now. So while there used to be a lot less contamination in general, and even when there was contamination, there were fewer types of contaminants and they were pretty well known, that's out the window at this point. So it's not just fentanyl. We have plenty of weird things that we're seeing in the drug supply. And I'm going to talk a little bit about kind of changing tactics for addressing this. So I like to say that the drug supply is splintering. I feel like that's a pretty good way to imagine it because it's coming apart, not just in the sense that it's changing, but it's changing in a lot of different directions. So in the past about 10 years, we've seen a move from heroin being pretty clearly the dominant thing for the opioid drug supply. And then we moved into heroin and fentanyl. And then before too long after that, we started seeing this snowballing. So heroin and fentanyl and fentanyls, so things like carfentanil. And then we started seeing the emergence of novel benzos like atizolam. And now we're getting into a point where if you have a sample of drugs from somewhere in North America, there's probably a bunch of stuff in it. And everything that I listed here are the usual suspects, things that we commonly get when we do drug supply analyses. So there's a lot going on here. And while that may be kind of an interesting sciencey factoid, let's talk about what that really means for the human element. So first of all, one of the major questions that I get is why this is even happening. So this is a really excellent example of the iron law of prohibition in action. So for those of you who aren't familiar with this term, this emerged in the late 80s from economics. It's the idea that with greater prohibition on some given market, and the big one being the illegal drug market, we see the emergence of harder substances and also changes to the market that reflect working with a low budget in a way that minimizes legal risk to manufacturers. And that may seem kind of obvious or vague, but what that means in practice is that we're going to see things that may result in a less pure, less safe drug supply simply because it's saving exposure to the law enforcement environment from the drug sellers, or for the drug sellers rather. So we're seeing things like the diversification of molecules in the drug supply, probably because it's a great way of not putting all of your eggs in one basket. There's really heavy prohibition on things like fentanyl, especially right now. So if a drug seller were to focus strongly on fentanyl and that happens to get shut down by the DEA, well, that's a pretty catastrophic situation for that drug seller. Proliferating and spreading out, avenues of investment across different substances, maybe coming from different places, maybe made in different ways, allows for their revenue stream to take hits from law enforcement without the entire thing collapsing. So this is something that happened to an extent in China with fentanyl. In 2017, the Chinese government then declared that they were going to shut down illegal fentanyl exportation out of the country. And while that didn't happen completely, there was a pretty big drop, and a lot of drug manufacturing for fentanyl, or fentanyl manufacturing, moved over to Mexico. And now we're also seeing some coming out of Eastern Europe, and there's generally been a spread of things around to accommodate that loss of production in mainland China. So in addition to that, we're also seeing this interesting move, and so far it's only been xylazine, but I'm interested to see what else comes up. An interesting move to above ground drugs that are made by illicit above ground manufacturers that are being diverted. So this is especially great because it avoids having to set up a lab. It avoids having to maybe grow a crop that can be identified and destroyed. So this is a picture from Chris Moraff, who's a drug war photojournalist and journalist. So he's based up in Philly, and Philly has always been the hotspot in the mainland for xylazine, which I'm going to talk about more in a moment. But he's been seeing like the actual manufacturer bottles of xylazine just kind of tossed here and there. We are seeing them show up a lot in drug bust photos. So this is an interesting example of drug manufacturers taking an above ground drug, diverting it from legitimate above ground manufacturers and putting it into the drug supply. So this is a really interesting move because it avoids a lot of the inherent danger and risk in operating with illegal markets. And this is just, at this point, fairly well known, but really excellent graphic illustrating the iron law of prohibition. Again, it's just pointing out that the harder we provide, or the harder we enforce prohibition upon a certain market or certain substance, that has historically over time prompted harder and harder substances. The one that we probably know the best is prohibition, where we saw a move into homemade spirits, aka moonshine, and the inherent risks that came with that. And one of the more recent things that's been in the headlines a lot lately has been how high the THC concentration is in cannabis. And that's something that was established preceding the large-scale legalization by the states. So there's a lot to say here. I won't spend too much time on it. So the very sudden and big boom in inconsistency in the drug supply does mean that we should tweak our harm reduction approach. And it also definitely means that we should adjust on the healthcare side. So healthcare professionals generally need to start investing more time and education into this issue. And I realize, having worked in a hospital for a long time, that that is very easier said than done, but I'm going to kind of make my argument for it here. So for harm reduction has always been centered in community and mutual aid. That's always where it's been rooted. When I first got started in harm reduction, that was one of the first things that Mark Henley taught me, was that if this is not based in community, if it's not based on collective action and mutual aid, it's not harm reduction. So this is good news because that's what we need right now. The more and more we see weirdness across the country, the more we see inconsistent responses and consistent reactions from people. We need to be able to share what works and what doesn't, what to look for. We need to be able to communicate and work together as a team. So we take care of us is one of the better known sayings in this field, and that's very true here. So one of the major focuses or foci in harm reduction lately has been very specific action-oriented harm reduction education, especially towards fentanyl. And none of this is bad. So it's things like carry naloxone, test your drugs, do not use drugs alone. These are all really great things to recommend to people. Having said that, it does kind of limit scope, right? Like it gives you a very specific thing to watch for and not much past that. So we're going to need to move more towards watching each other and having a general radar up for something being off, and then working together to figure out what we're going to do about it. So discussing xylazine again, and I can get way into the pharmacokinetics of xylazine that I don't have time for, but this is something that's consistently contaminating the opioid supply at this point. Over the past year, it's grown from kind of a blip here and there, and now we're seeing reports of it all over the country. And we're also seeing reports of things that suggest that xylazine is in places that don't have good drug testing. For example, it tends to cause really unusually presenting wounds that we're hearing a lot about. So chronic exposure to this, which is going to be common if you have someone who's using drugs on a regular basis, are kind of vague, and they're easy to excuse as something else. It's things like feeling tired, feeling kind of weak, faint, maybe you're kind of dizzy, and feeling weak and dizzy in the heat is unsurprising. You might kind of get cold easily because xylazine is really bad about causing anemia, it seems. And what's actually happening are potentially life-threatening issues. And a colleague of ours was almost killed by chronic xylazine exposure, and it required the very assertive intervention of a physician colleague to save that person's life, because a lot of this is kind of vague, and the physicians taking care of this person thought it was kind of preposterous that it could possibly be caused by xylazine because they just didn't know. So it also, even if we kind of look past that and we talk about something a little bit more acute, so what's right in front of us? Well, xylazine is becoming really well known for making people nod for hours at a time. So these people won't be able to move for hours and hours on end. So you can imagine how uncomfortable it is if you have to sit on your hand for 10 minutes. You're like, I really want to move my hand, right? Well, imagine if you can't move for 12 hours. So we're seeing people with bed sores, nerve damage, muscle damage, rhabdomyolysis, which is a complication of muscle damage. This is really dangerous for the kidneys, just from people not being moved by anyone around them. So I really hate stock photos in this world, but I think this is actually a good context to use because this isn't a real person. But this kind of position is what I'm talking about. So maybe someone who's bent over really dramatically at the waist. So that cuts off blood flow down to the legs. So we want to be able to, move people and put them in better positions. Got to kind of lean on some inpatient nursing almost at this point. Like, how do we take care of people who can't move? How do we keep them from getting complications? Well, this is going to be something else that requires community action. You need someone around to look out for you and take care of you. And this is something where we have to build this collectively as a community. Another good example of this kind of in action has been K2 and Spice. So this is a picture that I saved from my early days in the ER before K2 was quickly outlawed from sale in the head shops here in Texas. This was kind of how it was packaged. As you can see, it has some fairly hilarious typos on it. And even says not for human consumption. But this is a good example because while this has always been packaged as just synthetic cannabinoids, it really doesn't have anything close to that in experience consistently anyway. It tends to be really inconsistent and kind of shocking. So what we learned pretty quickly, and the community here in Austin definitely did, was that the best way to respond to this was just looking out for one another and to expect the unexpected and react as things happened. So this is something that we've done before. K2 is much less of a thing here in Austin as it used to be. Not that it's gone by any means, but this was something that we saw in real time. So the community that was using this really had to come together and just kind of watch out for one another. And that was a great example of mutual aid in action. So just kind of as a recap on this topic here, so a reminder that harm reduction has always been about community and mutual aid, always, always. So this is a really good news in a way, because we're going to need to really draw on that right now, because we're moving away from anything consistent. And every month we see more and more inconsistency in the drug supply. I feel like I'm hearing about a novel additive to the drug supply every couple of months as well. And there's only continuing economic pressure for that to continue happening. So when we talk about like teaching and communication within the harm reduction space, all of the good things that we have been doing to address fentanyl should continue. So that's not using alone, testing your drugs when you can, and watching out for one another. But in this case, it's going to need to be a little bit longer term. So we're going to watch out for each other, not just when we're using, but in general. So does this person look or act like they're maybe getting sick? Are they sleepier than normal? Or are there wounds that they're getting from drug injection? Are they not going away in a couple of days like they used to? Did this person faint? Has their appetite gone away? We need to start zooming out and looking at the bigger picture of health, because one big thing about this is that a lot of the substances that we're seeing showing up in the drug supply have not been researched in humans. So I really want to reiterate that we don't have data to go back on to say, what are we expecting from this? I can't tell you how many emails I've been getting from people that are like, what does the data say about long-term xylazine exposure on blood development? And I have to tell this person, no one has ever looked at that, because this drug was immediately moved to the veterinary market, and we don't have research on it in people. We don't know what it does in people. And even in the vet space, it's only meant to be used as a short-acting, short-term medication for sedating animals for procedures. So even then, there isn't research done on chronic use of xylazine in animals. We don't even have that to go off of. So as we keep seeing new drugs kind of emerging, or maybe drugs that haven't been seen since the 60s reemerging, we're going to have to kind of go into this blind and rely on one another to take care of each other. There's not going to be anything specific to look for. We're just going to need to keep a close eye on one another, and be willing to continue to take care of each other if we need medical help. So that's why I had to have this slide, because when I say, oh, hey, if your roommate or your friend, if it seems like they're getting sick, let's just go to the hospital. Well, it's never that easy. And if you use drugs or know people who do, you know it's not that easy. So healthcare spaces are very often spaces of considerable trauma for people who use drugs, and getting back to go see a doctor, to expose yourself again to ridicule, to stigma, to bad excluding terminology, to, you know, being treated without pain medication, to being told you're subhuman. I have seen it all and worse. I know a lot of us have. That's a really big ask. If you take someone who's maybe just kind of feeling in and saying, nope, it's time to go expose yourself to this again. So I am again calling on our healthcare colleagues to do better than this, because I know that we can. And the best way to really make a change is to act as an example for your peers. It's much more impactful if you see the nurse that you like and have fun with and is your work wife or whatever you want to call it, who actively rejects the use of stigmatizing language and treats their patient who uses drugs like any other patient, than to have to watch a module on stigma, or to be told by your manager that you shouldn't do that. it's much more impactful to see it modeled in each other. So I'm calling on all of you to start modeling this, because we're in a really bad way, and it's only getting worse if people who use drugs do not feel safe coming in to see us until they're at death's door. This is also a great opportunity, again, going back to the community aspect of harm reduction. We need to think together in our various communities about what we can do to reinforce and improve making healthcare spaces true healing spaces. What can you personally do in your clinic or hospital? What can you take to your manager? What policy can you implement? What can you personally do for the next patient who comes in who uses substances? Like, none of us here on this panel are going to have the magic wand answer. This is going to be something that we're all going to have to collectively work on and make effort on collectively. Saying collective a lot today, but that really is the crux of my argument today. All right, and as a reminder, the criminalization of substance use, the criminalization of homelessness, and in many ways, the criminalization of poverty undermines all of this community building that I just said was necessary. And this is very much on purpose. So I have to point that out, because none of this is going to be simple, and we're going to have to reinforce small scale action, because if we're just constantly waiting for a big scale change at the state level, at the level of an entire corporate hospital chain, it's never happening, right? So we're going to have to continue supporting community building despite these barriers, and that's going to be small, direct action on the ground. So there is no reason at all why healthcare people and harm reduction people cannot work together. There's no reason why healthcare folks cannot support, both directly and in softer ways, harm reduction in their community. What are you doing to support and connect with harm reduction in your community? Do you have a referral to harm reduction for your patients? Do you connect with harm reductionists on the ground to see what they're seeing and learn what they're learning? What can you do? What more can you do? All right. So healthcare professionals must be made aware of the splintering drug supply. And I've become a broken record on this, but this needs to be inserted into more ongoing health education. So sometimes that's as simple as, inviting the doctors in your life to these echoes, sending out journal articles, pushing and pushing and pushing until this becomes kind of a snowball within the professional groups. Again, going back to the power of hearing and learning things from your peers, right? And there's a lot of reasons for this. And one is kind of a patient-centered argument, like this is a good thing to do for the patients. But on a more kind of direct and selfish level, physicians don't want to be faced with total unknown and uncertainty if a patient comes in. They don't want to not know what to do and watch a patient die in front of them. So we really need to push this forward and get more education about symptoms to watch for in front of prescribers and people in healthcare. Again, I have to remind everyone, we are very spoiled that we have a beautiful, huge body of research on fentanyl in humans. We know so much about fentanyl in humans. It makes my life easier in some ways, because when people get really excited about passive fentanyl overdose stories, I can say, look at this gorgeous library of information. We know that fentanyl doesn't do this, right? Well, we don't know anything about what xylazine does to people. We don't know anything about what atizolam, fluoprazolam, these things that have been made of, they have not been studied in people. So we're really going to have to work together and not ignore what's going on here. So one of the things that I asked on my Twitter is, what are some good ways for healthcare professionals to stay aware of the local drug supply landscape? Going back to the idea that learning new things right now with as stretched thin as they are is hard. And I got crickets. So that's one thing that I would love to ask from y'all when we have our discussion time, is any good tips, tricks, resources that y'all have found in this process and can share? And that is it for me. This is me. Feel free to reach out, email, DM me on Twitter. Very happy to discuss any of this, answer any questions, and I think we're at a good point to move on to the case presentation.
Thank you so much, Claire. Thank you for stopping the screen share too. I'll open the floor back up. Questions for Claire about that presentation or responses to the question posed at the end of it, ways to stay aware of the drug supply landscape.
Thanks, Andrea.
Yeah, Lindsay.
I see Lindsay.
Yeah, so I think that the sites like drugdata.org, and it would be really nice if we could have drug testing here, would be amazing. But I know they do it in the northern states, so that kind of gives you an idea of where things spread sometimes.
Yeah, absolutely. Drugdata.org, and I'm going to put it in the chat here for everyone. That's the one suggestion that I did see. And I will, and so, yeah, great minds, Lindsay. But the, just echoing that a huge hurdle that we have is just really poor data in Texas on what we have here.
I also just wanted to thank you for the presentation. We do need drug testing like what they have in North Carolina, Chicago, and San Francisco right now, that triangulated testing with mass spectrometers and fentanyl test strips. But we're just not there yet. And if it was any other epidemic, like their spinach was bad, if there was any other public health epidemic going on, you wouldn't test after the fact, after the people were dying, you would test beforehand. But I also wanted to point out there's kind of an opposite phenomenon of the iron law of prohibition. I was lucky enough to go to Copenhagen and hang out with the drug users union there. And in Copenhagen, they have, when I was there, they were doing a free pilot program of free prescription heroin. For people, who qualified. They have much easier access to methadone and buprenorphine. Obviously, they have social services, social safety net that we don't have, and healthcare. But the illicit drug supply was about as pure as you could find anywhere in the world, and it necessarily had to be because it had to compete with things like methadone and prescription heroin. So those policies, again, it's the criminalization that has pushed this into the shadows and has created this adulterated supply. And that is one option that Western countries have taken to push back against that. But yeah, I just wanted to thank you for the presentation too.
Yeah, thanks for adding that, Chris.
I'm
seeing some.
Go ahead.
I'm sorry. I was just saying I'm seeing some good links in the chat as well. Go ahead. I'm sorry.
Now, how much of a drug called ISO are we seeing in Texas?
Yeah, so I have, again, it's hard to say because we have really bad drug testing in Texas. I have one confirmed report of it from Houston. And just based on the patterns that we're seeing in other states, I suspect that it's here. I don't think it would make sense for it to not be here because we have it all along the eastern seaboard into Florida, and then it crawled over to Georgia, and then it crawled over to Alabama, and now I also have reports of it in California, which has much better drug testing. So I would be quite surprised if we're missing ISO. But it feels and acts very much like fentanyl, so I think it's one of those things that can really stay under the radar unless you actually go look for it on a test. It's a good question.
Yeah, they're saying it's like 20 times or 50 times stronger than fentanyl, or something like that.
No, it's not quite that much stronger. I did a paper on it, which is why I know.
Okay.
I'm not trying to be too annoying.
Yeah, exactly.
Yeah, no, it's slightly stronger and slightly more potent than fentanyl, but not that much stronger. So honestly, based on the receptors that it talks to, its potency, its efficacy, and all of those other things, all of the data that we do have on it, it probably feels quite a lot like fentanyl.
Okay.
So it's just another variation on a theme.
Cool. Wow.
Yeah, good question though.
Thanks.
Thank you, Sean. And we'll actually go on and jump over to program announcements from Be Well. Carly with IT, would you mind going ahead and screen sharing that? While she's pulling that up, I do just want to draw everybody's attention to the wealth of resources populating the chat. everything from Aaron sharing information about xylazine resources and community outreach, or Chris putting in some more information and evidence about the detrimental impact of provider stigma on healthcare access, and even more, and folks reaching out seeking resources. So feel free to interact, continue to put conversation in the chat. But let's talk about some updates from the Be Well program. So as you know, Be Well Texas is a welcoming environment with caring professionals ready to help people start or continue their journey towards recovery. Be Well is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. The clinic now offers low-cost, self-pay, and no-cost services for patients affected by substance use disorder, and they also have insurance options available. Next slide, Carly. Coming soon, a couple new ECHO programs, a public safety ECHO for public safety professionals and first responders, and also a substance use disorder ECHO for behavioral health that is directed at behavioral specialists. Next slide, Carly. And we do hope to see you back again here next month for our next harm reduction ECHO on August 4th, same time. And last slide. And then certainly do remember there's a whole portfolio of programming available through Be Well Texas. So we're going to continue offering the TexRx, RSS, and Shout series. And just so you know, there's now a one-time registration link for each of these series. It makes it very easy to get all of the echoes on your calendar. And you can register for all of them at bewelltexas.org. And Carly, you can go on and stop share, but I do want to toss the mic over to Adrienne Lindsay, who's going to make an announcement about an upcoming webinar.
Yeah, I know we usually make people aware of other upcoming ECHO sessions, but there is another opportunity this month on the 20th at 3 p.m. and we will drop the registration link in the chat in just a moment. Many of you are probably familiar with our annual conference, the Texas Substance Use Symposium, and sort of leading up to that, we have what we call Texas Sessions, which are webinars to kind of get everybody primed for the content. So on the 20th, we'll have a webinar on alternative payment models for treating substance use disorders. So if you're looking for sustainable funding models to provide your said treatment services, we'll be talking about models other than fee-for-service and kind of the more traditional payment models for treatment. So we hope some of you will join us. And again, the registration link, it looks like, was dropped in the chat. So, and that, like all of our offerings, is a free session. So.
You'll see that from Krista Friedrich in the chat there, and it'll also be included in post-session communications too, where we'll share the other resources you're seeing populate the chat. Well, at this time, let's turn things over to our case presentation and discussion. Carly is going to go on and share the case form that you filled out. Sean, when you're ready, can you talk us through this case for today and your questions about this situation? Oh, you're still muted. There we go.
All right. Sorry about that, everybody. So my name is Sean Southern, and I work for Recovery Resource Council, and we're in the Dallas-Fort Worth area. And I am with the exciting program called the Overdose Response Team. And I'm a peer support specialist with them, and we are partnered with MedStar in Fort Worth. And so we follow up on 911 calls that they make for overdoses. And we make contact sometimes with patients who have overdosed or had a near overdose experience. And this program is taking off. It is, we are making a difference. We truly are. So RRC is a 75-year old company, and they have their roots deep in the ground here in North Texas. Becky Tinney is our director, and she's a visionary. She is truly a wonderful, wonderful leader. And I can't say enough for her. She is a blessing to us. So we came across this case. She's a 23-year-old female. She is a known heroin user, substance user. This was a full-blown CPR her dad found her in the bathroom because he heard a thud as he was walking by. Tried to arouse, tried to get her attention. The dad tried to, in vain, tried to open up the door, calling her name, trying to push the door open and couldn't because she was on the other side of the door between the door and the sink. So the dad punched through the door and started tearing the door inward, trying to get to his daughter. Called 911, put the phone on the floor, and was just screaming, "Help me, help me, help me." So pulled her through that hole and began chest compressions. Fire arrived on scene. They took over, gave her Narcan, brought her back into the state of walking, talking, and fighting. She did not want to go to the emergency room. The medic, thinking quickly, said, "Well, you can go to the emergency room, you can go to rehab, or you can go to jail. Take your choice." And she hopped on the stretcher and went to the emergency room. So we got a hold of her after she went to rehab. She called us. I went up and saw her. We made contact, and she said, "I need help. I need a lot of help." She is, oh boy, she has, as you can see, she is a drug of choice. Went from heroin to fentanyl, to anything that she could get a hold of. She's mostly a social drinker. She her no real issues with the drinking per se. I am, of course, encouraging abstinence with the drinking, but I can't force it, and I'm not going to force it with her because I'm so proud of her right now. She kept tripping up on the methadone that she was put on, and I keep having this problem with. She was diagnosed bipolar while she was in treatment, and I keep seeing this a lot with bipolar patients and methadone. 30 days in, bam, and they relapse. And you can have all the support pieces in place and have all the pieces to the puzzle in place. It keeps happening. And it's not, I have other peers tell me the same thing. So this time around, I said, go pick a rehab doctor and go talk to a rehab doctor. This time around, she did this. And so far, she's been on Suboxone for 4 weeks now, and she's doing great. And so part of my questioning today is there a connection between a dual diagnosis and Medicaid, running your MAT services? Are we missing something here when we're diagnosing people with bipolar or other mental disorders and substance use disorders? Is there a link? Is there something that we're missing? Because I'm seeing it a lot, that a lot of the methadone people that I work with, a lot of our clients are saying, "I don't know what it is, Sean. I just cannot get it." I see them trying everything. They're using 12-step. They're using alternative. They're working their steps. They're calling every day. They're saying, "Hey, Sean, I'm really craving," and we talk and we work and we do everything, and you put them on Suboxone or they're using something, and it changes the landscape of how they're feeling and how things are going. And so my question is right there in the box, is there something that we can do different or is there a study out there? Has anybody studied this? The end. Oh, there's our scores. And
Yeah, let's talk us through that. Carly, thanks for drawing that to our attention. I think we can probably scan through this quickly, but Sean, is there anything else you want to bring up from what Carly's on the page?
Really, she has some trauma in her life. Her brother tried to kill her twice, her own brother. Tried to drown her, and this is all confirmed by her parents. We have a pretty tight bond. I'm a recovering addict. I'm sorry, I didn't mention that. I'm a recovering opiate addict. I have 15 years of clean time. And as I told her, I said, I'll be in recovery the rest of my life. And so will you, as will your parents. Your parents are recovering with you. And I said, trauma, we got to get you help for. We've got to get you help for this. And she said, I don't want to talk about it. I said, you have to talk about it, or you're going to keep doing the same thing. And once she started talking about it, things started changing. But she was still on the methadone doing this. And she brought this out, and I thought, yeah, that's important. Yeah, somebody trying to kill you, a loved one. Yeah, that's pretty important. But there were things that she was blaming herself for. Her boyfriend, when she was 16, died in a car accident, and she blamed herself. And so we started working through all these problems and getting her help. And so I said, have you ever seen a rehab doctor? And she said, no. I went, where'd you go to rehab at? And so we went into that, and I told her parents, I said, did y'all get involved in this? Her dad said, I did. And they have a very tight bond. And I asked Dad, Dad, you got to walk with her again. And he said, I'm afraid to. I think I did this to her. I said, you didn't do this to her. And she didn't do this to her. This is a disease. And you wouldn't walk away from a cancer patient, would you? And no. And I said, then why are you walking away from her? So he said, but she's not getting it. I said, I don't think it's her not getting it. I said, I don't know what it is, but I'm going to find out, because I'm just seeing too much of it. And it's like they switched to, I'm a Suboxone fan, number one, but even if they go to a different program or a different medication, it's like it's like it wakes them up, and they're like, okay, does the methadone put them in a fog along with their bipolar medications? God, there's got to be something that it's just driving me nuts. It's driving me. Maybe I'm a.
Hi, Sean. This is Angelita. Am I able to chime in?
Go ahead. Yeah.
Yeah.
Hello. So I'm an LPC, and I've had a lot of experience being exposed into the criminal justice system, and having the chance to work within a program for substance use and mental health diagnosed or co-occurring diagnosed individuals. And so we, in that grant program, we were able to combine treatment with therapy practices and sessions, group, individual. So through my experience in that 3 years, I found that to be very complementary to a person in recovery. So that was something that I was a big advocate for. As far as digging into, like what you said, a lot of the traumas have been rooted really deep in. And then I think I heard you say something about, the transition to a different, like medication treatment, whether it's Suboxone. We provided a lot of the naltrexone.
Yeah.
That treatment, because, and to the cost, right? So the cost is usually a factor because it's so expensive to maintain, and the federal grant we worked under was able to provide, but only a certain amount of funding, right, to pay for it. And so the biggest thing that I always pushed was that therapy. And then the component of incorporating the family, because a lot of times there's that rejection or that bias or that, judgment of, oh, well, you're going from one substance to another, how are you going to get out? But it really takes a team, it takes a tribe. And I'm not sure if, because you kind of shared a little bit more of your experience, but I'm not sure if that was something that was true for your recovery to be a success for this long. But yeah, I think that, as much as there's already so much stigma around an individual using a drug, the severity of the drug, it already has this multiple damaging internal view of one's person. And so they're constantly having to remind themselves, I'm an addict, I'm this, I'm that, all of the labels. And so one thing that I learned, and I love to just share this idea or concept with others, is that working in the jail for 3 years and trying to understand the hardcore roots of trauma is the one component I feel like was the best part about my practice was incorporating love.
Yep.
So people are like, what did you do? What did you find? And it's more of just the compassion that you provide that person to say, you're human, we accept you, and you are continuing to change your life every day. So that's something I just wanted to kind of give you some feedback on, because that's what I want to continue to do. And I'm going to be going back into the criminal justice system for that reason, because there's so many people that just need to hear they're accepted and be validated through their experience.
It takes a special person to go in the jail. I worked for the sheriff's office for 6 years also.
Mm-hmm.
It takes a special person, so kudos to you.
Thank you.
Yeah, thank you for bringing us back to that sense of community and reducing stigma and bringing love. Lindsay, I've seen your hand up for quite a while. I want to make sure we get you some time.
Yeah. So I mean, I'm a peer specialist, right? So I'm not a doctor. So I caution on, if somebody's working with a physician, to be very careful not to overstep that bounds of kind of trying to sway them to or not to take a medication. I think, if their doctor knows that they're on other medications, they will weigh the risks and the, everything that goes along with that prescription, right? So it's really hard to, and then on the other side of that, being a peer is not necessarily, if somebody is not ready for, classic sobriety, then maybe that's not the way for them to go. Maybe, maybe they would be interested in something like harm reduction, like moderation management or something along those lines, where I think we get this very black and white. It's you either have to be abstinent or nothing. And that can often cause kind of a struggle, And then the last thing I'll say is that very often substances are not the problem, they're the solution to a problem. So if you've got somebody who's got a long history of, like myself, I have, a long history of struggling with mental health, that came before the substances ever came for me. So I had to deal with that before I could deal with the substances, or I would just fall back to my old patterns.
So do you think that since she hasn't been dealing with the mental side of things because of the aha moment, that this is a setback for her? Because now she's having to turn around and figure out, okay, what is bipolar? I mean, now she's got to figure out a whole different process. Like, okay, what does it mean to be bipolar? She has a whole different world.
It can definitely help. One of the things I've always advocated for is, I think that we should merge mental health and recovery peer specialists. That's my own soapbox, but part of that is that you've got the underlying issues. Those need to be, so you can get help in, if you think that maybe she's struggling with that, maybe suggesting that she talk to a mental health care specialist who's, trained in that as well. But again, it's her choice, right? So we meet where they're at, and we help them with what they choose to do and what they want to do. To has to be participant driven.
Support their educated decision.
You're getting some Zoom applause from Claire and echoing of your statements in the chat there, Lindsay. Aaron, yeah.
Yeah, I'm going to give the wrap up here. So if you want, if somebody else had a question, I can just speak whenever it's time for that.
Sure, yeah. Angelita, I think I muted you just because we were getting feedback, and I think you were going to say something. But let's open the floor. Any other thoughts or guidance for Sean?
No, I was just going to validate that statement as far as following or digging more into the mental health side, because it comes back to the fact that when the heavy drug use started is kind of when that development and that processing and all of that may have had a big halt in it. And so they're having to, reintroduce themselves to who they left behind.
Yeah.
And so that does take, that therapy and that process to happen.
Cool.
But thank you.
Thanks.
I've got a couple of things. We're going to send out an email after this with links to a lot of these resources. But what I hear people saying, and I appreciate that, is we want to keep in mind that the choices our participant makes aren't necessarily the choices we would make or want them to make. And we stand by them and practice radical love, right, as opposed to tough love. So kudos on doing that and sticking by her. The thing about co-occurring conditions and illnesses, I mean, those are there. I have never known of a case of severe substance use disorder that didn't have a co-occurring illness. And sometimes those exacerbate those, but they exist. Yeah, they exist and they need to be addressed. So I put in some resources about EMDR, about harm reduction psychotherapy, and about some of the research into psychedelics, particularly for that kind of trauma. Looking at her ACE score too, I was wondering if a psychiatrist did the ACE test with her, or if she had done that self-reported. Because oftentimes, if you're doing it with a trained professional, they will be able to. Your score gets a lot higher when you have.
Hers was actually a 5, and her resilience was a 12.
Okay, yeah, it said 3 on the thing, so that confused me a bit.
Yeah, that was I thought it was a 3, and it wasn't. Yeah. She goes, no, that's a 5, and I was like,
yeah, and likely higher again if she had somebody go through that's trained to do that. The other thing, I wanted to send some practical things to you. One is a partner checklist for overdose prevention. So it's not just another sheet that talks about, but it's actually questions that she can use to go over with loved ones, with people she uses drugs. Like, does she want them to call 911? Does she want to go to the hospital? Where is her Narcan, right? Yeah. Really common sense questions that people need to have conversations about. Also, some sheets about opioid withdrawal, like home withdrawal, about harm reduction with the benzodiazepines she's taking. Because with Suboxone, it's not that much of a risk, but there is harm reduction that she should be informed of. And Sean, these are things that I'm sure you wouldn't do it. Many times they're just passed to people, but they're so interesting.
It's all provided by us.
Yeah. And I'm going to send some different stuff, and we'll see if it matches up. Because I've never heard of anyone having an OD checklist before.
We actually I downloaded one off the internet.
Oh, good. Well, that's great. Well, I'll put it out for.
I'll take whatever you guys got.
Great.
You can never have enough information.
And then just super quick to reiterate what everyone else had said, that sense of community is so important. And if she's not getting it, and it sounded like Narcotics Anonymous can sometimes be stigmatizing against people taking buprenorphine, for sure, and definitely people who casually drink. So, offering those other support groups, like there's a National Drug Users Union, there are harm reduction work support groups. We'll put a link to the National Harm Reduction Works in the follow-up email. And that is all I got. Mostly it's just about that radical love, and we just keep showing up and walking next to people, right, as they navigate difficulties. So kudos
for your educated decisions.
That's beautifully said, Chris, and thanks for the generosity with the resources. We'll get those to you, Sean. Aaron, you have the unenviable task of maybe summarizing some of the key points from our conversation today. And if there's any more you wanted to add too, please take it away.
Yeah, I want to thank everybody for your time today and for your input. Thank you, Claire, for the great didactic that you gave. There was a lot of really useful information there, and thank you for urging us to build community around this issue in places where people have none. Texas is a place where there's a lot of community needed. There's very little community for people who actively use drugs and don't have a goal of sobriety. And harm reduction is the answer to that. Drug use organizing is the answer to that. And thank you for reminding us of that. And thank you to everybody who weighed in about the case presentation. Thank you, Sean, for working with this person. There aren't a ton of harm reduction resources in Texas. And so I really want to prop up and encourage all the people that are fighting this fight here and continuing to advocate for harm reduction and encourage you to keep doing that because this is really life-saving. It saved my life and it's saved many lives of people that I know. So when it came to some of the recommendations, something that struck me off the bat was one of the central tenets of harm reduction is always building our interaction with people on the basis of their goals and values. So the person that we're working with may not have the value of sobriety. They may not have the value of abstinence. They may tell you that they do, but in reality, they may not. And it takes time and effort to determine and build a relationship and rapport with a person to find out what their actual values are. And harm reduction is always built from the basis of individual values, and that's going to be different for everyone. Some of the recommendations that were made were practicing radical love and acceptance, being understanding of the stigma against people who use drugs, understanding that substance use may once have been adaptive, or there are instances in which using drugs is adaptive. I probably wouldn't be alive today if I hadn't used drugs. Being mindful of the division between physician and non-physician conversations. It's often the case when it comes to a prescribed medication that there's a lot of information flying around. And at the end of the day, the best person to make that decision is the doctor that they're meeting with or a healthcare professional who's prescribing the medication. And that's always going to be the safest option for folks. Lindsay mentioned that harm reduction is an alternative to maybe an abstinence-based approach that might cause frustration. If we have a goal of abstinence for someone and they're continuing to use, that could be frustrating. So really finding out what their goal is. Digging into her history of trauma was another thing that was recommended, which is, I think, really important. And thank you for identifying that, Sean, and for working with this individual around some of that stuff. Finding a bipolar treatment provider that will coordinate with medication-assisted treatment is important because it's often the case that people get trapped in between those two systems. Each provider is saying, I won't treat you because you're on the other medication. And we know that both of those conditions can be treated concurrently in a safe manner. So we want to make sure and do everything we can to coordinate care with whoever can treat the bipolar disorder and get connected with the mental health services for trauma. Chris is going to follow up with some information that just practical use information regarding safety. We know that this person has a history of overdose, and we really want to make sure that we can prevent that. Abstinence may not be the best way of preventing that. If we know that there is use in the future, we need to have an honest conversation about safety. There was something mentioned about the door opening inward and the person falling on the door. There are things to think about in terms of the context in which a person is using that we can make sure and be preventative. Because people who stay alive tend to thrive, right? We want to make sure that people stay alive and can thrive. And so we want to be able to provide you with some resources, Sean, and continue to encourage you in the harm reduction work that you're doing in Dallas. So please continue this conversation with us about harm reduction. We are breaking into a very difficult place to practice these things. But I think that if we can all come together with the type of community that Claire has recommended, that we can build a system here that will save many lives. So thank you all so much for your time today.
Hey, thank you all for
Thanks
being
again,
here.
Sean.
Hey,
I can't say it
Thank
much
you.
better than that. Thank you, Sean and Aaron. Thanks, Claire, to our for the presentation, and to all of you for making this community what it is. You'll see over there, Carly has put in a couple times that link to the post-session evaluation. Please give us your feedback. It'll stay open for about a week. We hope to see you on August 4th. And until then, I hope you're moving forward from a place of honesty, gratitude, and like we discussed today, radical love. Thank you, everyone.
Thanks, guys. Appreciate
Bye,
you.
all. Thanks for coming.
Bye.